Welcome everyone to our discussion on the nuances of immunotherapy, biomarker testing in solid tumors, unraveling complexities and overcoming challenges to improve outcomes. Today we've assembled a splendid panel of speakers. Our speakers today are Dr. Hossein Borgai from the Fox Chase Cancer Center and Dr. Jonathan Novak from the Brigham and Women's Hospital in Boston, Massachusetts. Dr. Borgai is a professor of medical oncology, director of thoracic medical oncology, co-leader of the thoracic cancer service line, director of the lung and head and neck cancer risk assessment program at Fox Chase Cancer Center in Philadelphia, Pennsylvania. Dr. Borgai has immense expertise in these fields. He's interested in lung cancer, mesothelioma, and thymoma. He's a member of ASCO, and IASLC and numerous other groups. He was on the NCCN lung cancer and mesothelioma panels for several years and has published numerous studies in very prestigious journals, including Journal of Clinical Oncology and the New England Journal of Medicine. Dr. Novak joins us from Boston, Massachusetts. He's a pathologist at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, and is an assistant professor of pathology at Harvard Medical School. He did his medicine from Cornell and his PhD from Rockefeller, followed by a residency at Brigham and Women's and fellowships at Harvard Medical School and Brigham and Women's Hospital. He's board certified in APCP as well as in molecular genetic pathology. As a molecular pathologist, Jonathan helps design and interpret NGS assays for clinical tumor characterization and also leads a newly established constitutional genetics testing service focused on hereditary cancer predisposition. So I am a lung pathologist and director of lung pathology at the Cleveland Clinic. So I will hand it over now to Dr. Borgai for the first part of this session, which will be a clinical overview of immuno-oncology. Please take it over and welcome, Haas.
Thank you so much, Sanjay, for that wonderful introduction. Immune checkpoint inhibitors have drastically changed the treatment landscape for a number of solid tumors, including tumors that we never thought we would be using immunotherapy, such as non-small cell lung cancer. Sometimes you hear melanoma and you kind of have the historical background of immunotherapy being effective, but not in some of the other tumors. And again, since lung cancer is my specialty, and I'm sorry that I keep going back to that throughout the discussion, but the bottom line is that, as we will show you pretty soon, the checkpoint inhibitors have had a major impact in a number of malignancies. Now, a simplified version of talking about immunotherapies that we have access to is shown on this slide. Basically, we're talking about two different categories of checkpoint inhibitors, CTLA-4 inhibitors and PD-1, PD-L1 pathway inhibitors. And again, in a simplified way, if you look at the left-hand side of this particular slide, you see that we kind of think that the CTLA-4 inhibitors work mostly on the peripheral lymphoid compartment, but the PD-1, PD-L1 pathway inhibitors have more of an impact on the tumor microenvironment, again, the way the dogma is right now and how we think about it. But the bottom line is that these are both negative regulators of T-cell activation, and therefore using an antibody that inhibits the CTLA-4 pathway can lead to T-cell activation in the peripheral tissue. Likewise, if you use an anti-PD-1 or PD-L1 inhibitor, the tumor microenvironment, and block that particular interaction, you can have T-cell activation and therefore the desired effect of having an immune system that's activated and can act on the tumor. There is now plenty of evidence that as monotherapy, the currently available checkpoint inhibitors have significant impact on a variety of malignancies, as you see on this particular list. We're not going to cover all of the data here because of limitations on time and all that. What we also realize is that even though the checkpoint inhibitors have been very, very effective and have changed the way we think about treatment of various malignancies, the work is still not done. Not everybody benefits from these treatments, particularly when you're talking about monotherapy. Therefore, we've gotten into combination studies. In the world of lung cancer, for instance, combination with other checkpoint inhibitors, with chemotherapy, sometimes even in other diseases with targeted therapies in terms of oral TKIs, we now have been able to establish pretty good clinical efficacy for these combinations, trying to expand the number of patients who could potentially benefit from all of these. The bottom line, however, is that not everybody benefits. So how do you choose patients who are truly going to benefit from these drugs? And therefore, you can spare toxicities and perhaps cost to patients who are not going to benefit from this. A number of different biomarkers have been investigated or still under investigation. And the topic of today's discussion is PD-L1. Before we go any further, I'd like to point out an important aspect of what we're talking about, particularly in the world of non-small cell lung cancer. When we discuss the use of checkpoint inhibitors, I'd like to emphasize that we are talking in general of patients who do not have a molecularly driven tumor in the setting that we are discussing. The use of checkpoint inhibitors in patients with tumors that have molecular alterations is not really established. Therefore, we are talking of the so-called wild type, which is a term that we're not really using as much anymore. So please keep that in mind, that at least in the world of lung cancer, we're not talking about patients with EGFR, ALK, or other alterations that have now been used. But what we do have is PD-L1. I'd like to see what my colleagues think about this, but we as medical oncologists, at least I, think of PD-L1 as an imperfect biomarker. There are a lot of issues with it that we're going to discuss. There are different platforms, there are different antibodies used. Every company that has a different checkpoint inhibitors have a different cutoff. So there's been a little bit of a confusion in the beginning as to how to use this particular biomarker, and we're trying to, throughout this discussion, clarify some of that. But for instance, what you see on the slide here is that based on level of PD-L1 expression, we have drugs or drug combinations that are now approved for different populations. For instance, the combination of nivolumab plus ipilimumab is approved in the world of lung cancer for patients with any PD-L1 expression, as long as the tumor does not have an EGFR or ALK alteration. Similarly, for pembrolizumab, again in lung cancer, any PD-L1 expression 1% or higher qualifies a person for use of pembrolizumab. In other diseases such as head and neck malignancies or cervical or gastric, a different way of measuring PD-L1 or a different cutoff, as you see for urothelial cancer or esophageal tumors, have been used. Atezolizumab, a very similar indication. Again, in lung cancer, you can define patients with high PD-L1 expression without an EGFR or ALK alteration, and patients might qualify for the use of atezolizumab as a single agent versus chemotherapy. Same thing with triple-negative breast cancer or other urothelial cancers. Again, defining patients based on the level of PD-L1 expression, based on the clinical trials that have been shown clinical efficacy based on different cutoffs. We see the same thing with cemiplimab at the bottom of the slide, where TPS greater than 50% is a criteria for using this particular agent in non-small cell lung cancer. So what other biomarkers do we have? And again, my colleagues will cover this a little bit more in depth. We realize that MSI-H is another potential biomarker. We know that pembrolizumab has approval in this setting. And also, it is one of the tests that, as a matter of routine, we're now getting from most of our pathologists. And again, we're going to discuss how do we go around doing this testing, how do we make it a little bit more uniform. And then most recently, we have an indication for pembrolizumab in patients with high tumor mutational burden. TMB has been a little bit controversial, and we're going to talk a little bit more about the data, but we do have a nicely conducted clinical trial in patients with various malignancies, where based on a TMB level, it's defined as high, pembrolizumab has shown clinical efficacy, and therefore it is a potential biomarker to use in certain tumors. But again, as I said, there are some controversies around this that hopefully we will cover. So how do we use PD-L1 testing in a setting of a patient with a non-small cell lung cancer? Well, this is a typical case, 69-year-old male, former smoker, a good performance status, symptoms that can be attributed to a malignancy such as fatigue and weight loss. Unfortunately, imaging study shows the presence of a lung lesion with evidence of metastases. A biopsy shows adenocarcinoma. Routine NGS testing does not reveal any genomic alterations that can be targeted, and the PD-L1 testing is ordered. And the question here is, how do we interpret the test and how do we use it in a clinical setting? So we're going to come back to this particular case after discussing PD-L1 testing. So Sanjay, back to you.
Thank you, Haas. It's always a pleasure to hear. I always learn something when I hear these things from you. And what I'm going to do now is essentially take people through what it takes to test for PD-L1 and what it looks like from a pathologist perspective to test for PD-L1 in these patients. So the topic of this talk is going to be simply PD-L1 expression. So the first thing that people need to know is that there are, as you briefly touched on, Haas, is that the scoring systems are extremely complicated. Now it's relatively simpler in my field, which is lung, in that the system that we use, at least at my institution, is based on 22C3 and the tumor proportion score, which is actually a very simple concept. All it is essentially a percentage of the tumor cells that are positive for PD-L1. And so that's what the tumor proportion score is, and that's used for 22C3 or SP263. There's also a TC, which is essentially the same thing, which is used for SP142. And then we come to more complicated scoring systems that take into consideration both the tumor cells and immune cells. So there's an immune cell scoring system, or the IC, that is used for SP142. And there's the combined proportion score, which is takes into account both tumor cells and immune cells, which is, I think, the most complicated system, but is also used for 22C3 in some situations. So people must be aware that there are different scoring systems depending on the particular antibody you're using and the particular tumor that you are using it for. Now, this is the current system is in this way because there are different IHC assays tied to different drug combinations. So, for example, pembrolizumab, the second one in here, is which is an anti-PD-1 therapy, is tied to the 22C3 as the companion diagnostic, and there uses a tumor proportion score of more than 1%. On the other hand, if you look at this nivo-ipi combination, which is anti-PD-1 combined with an anti-CTLA-4 antibody, it is tied to the 28-8 as the companion diagnostic, and again requires more than 1%. You'll see on the other hand, cemiplimab, which is on the right-hand side, anti-PD-1 therapy, is tied to 22C3 and has a different cutoff, has a 50% cutoff. So it really gets very, very complicated very quickly. So I'm going to show you an example of what we use at our institution for lung cancer. So this is purely, my discussion is purely limited here in these slides to lung cancer, non-small cell lung cancer scoring using the 22C3. So first of all, only membrane staining is positive. So here's an example of a non-small cell carcinoma with membrane staining. Pathologists would be familiar with this from HER2, for example. The same concept applies here. If it's membrane staining, it's positive. Otherwise, it's not considered positive. In lung cancer non-small cell carcinoma, we count only tumor cells, not inflammatory cells, so that makes the count relatively easy to perform. Here's an example where all the tumor cells are positive in this particular field. The only pitfall really and difficulty that pathologists face in this count is that macrophages are also positive for PD-L1. And what you have to remember is do not count the macrophages when you're doing this kind of a count in the lung. So here's an example of some alveolar macrophages that you see the H&E on the right and the PD-L1 stained slide on the left, and of course you can see that they are positive. This can get complicated because sometimes macrophages and tumor cells are present in the same field, obviously, and there you have to tell which ones are the macrophages and which ones are tumor cells, and that's where the expertise of a pathologist is very, very helpful. In these pictures, the tumor cells are at top left and the macrophages are at bottom right. this picture shows you how you could misinterpret a tumor proportion score if you don't know that macrophages can be positive. So for example, if you quickly look at this field and say, hey, there's some brown staining membrane positive cells, let me call this, I don't know, I'll count the cells and call this 10%. But you would be wrong, because the cells that are staining are PD-L1 positive macrophages. In fact, the score here is 0% because none of the tumor cells are staining. Another thing to remember about PD-L1 staining is that any intensity of staining is positive. Of course, this at some level, this makes the scoring easy, but it also creates some trouble as to at the very lowest end of the positivity, it becomes sometimes difficult to judge whether something is very weakly positive or negative, and that can be a challenge. So in this picture, for example, on the left-hand side, you see strong PD-L1 staining, which is never a problem. It's very easy to identify. And then on the right-hand side, you see weak to moderate PD-L1 staining, which sometimes is easy, but at the weaker end of the spectrum can be difficult. To complicate things further, the intensity of PD-L1 staining can vary within the same tumor. So it's not always that all cells are equally positive. In fact, within the same tumor, you can have some cells that are strongly positive, some are moderate, some are weak, and some areas, of course, can be negative within the same tumor. I would end this by saying that the end output of your results should be the percentage of tumor cells that are PD-L1 positive with this particular scoring system. And so in our practice, we simply report a number. So for example, 5%, 20%, 80%. I would suggest to pathologists, don't give ranges. Don't say more than 2%, less than 15. That sometimes causes problems for oncologists. You will get a phone call. If that particular cutoff is clinically significant, your oncologist will call you and ask you, hey, what do you mean by this? Is it 5 or 15? So try to give a number, acknowledging that it's not always easy. So with that, I'm going to hand it back to Dr. Borgai for continuing the discussion.
Great. Thank you for that overview of PD-L1. And believe me, I feel for my pathologist colleagues. I think the demand on the tissue and the number of testing, all the things that we are asking you to do is a lot. And we definitely feel bad because often we cannot provide you enough tissue, and we understand that. But this is where the clinical practice is going. And I think the collaborations within medical oncologists and pathologists and that open communication is extremely important. I'm glad to hear that your medical oncologist might call you. I think that's necessary when it comes to something so complicated and something that can have such a great impact on how we treat patients with various malignancies. And again, we're using lung cancer in this setting. So feel free to call each other. I think that's really important. So how do we use the testing? So let's go back to this sort of a complicated slide. So why is it so complicated? Well, because for every patient with a diagnosis of metastatic non-small cell lung cancer, we could have several different options. Depending on the level of PD-L1 expression, a physician might have a chance to treat someone with single agent checkpoint inhibitor, or a physician might have the option of using chemotherapy in combination with either a checkpoint inhibitor or 2 checkpoint inhibitors used together. The list is a little bit exhaustive, and I think the key thing here is to give you a glimpse of what a medical oncologist goes through when they are seeing these patients. So we have our NGS. We've decided that patients do not have a molecularly driven tumor. Therefore, targeted therapy is not the option. So the next level of decision is, what is the PD-L1 level? In general, and again, I don't have a good slide to show you for this, high PD-L1 levels, which for now are defined as those tumors with at least 50% or higher PD-L1 expression. In general, we have an option of treating them with single-agent immunotherapies. I'll show you in a moment a couple of studies that actually say you might have the option of using PD-L1 cutoff of 1% in lung cancer and offer potentially single-agent immunotherapy. That's not normally how we would do it for patients with lower levels of PD-L1 expression. We favor a combination, and again, the data is going to be presented. So one of the studies that we talked about is Keynote 042. This was an international randomized phase 3 study in which patients with a diagnosis of advanced non-small cell lung cancer with at least 1% PD-L1 expression based on 22C3 antibody that Sanjay just covered were randomly assigned to receive either standard platinum doublet chemotherapy or pembrolizumab as a single agent. Again, a little of a busy slide. If you look at the top left-hand Kaplan-Meier curve, PD-L1 over 50%, we already knew from Keynote 024, which was done several years before this one, that patients with a PD-L1, with tumors that have PD-L1 over 50% can actually benefit from single-agent pembrolizumab versus standard platinum doublet chemo. So that subgroup was already defined as a subgroup of patients who can get single-agent pembrolizumab and not have to get chemotherapy as part of the treatment. And this study sort of confirms that. The blue curve is pembrolizumab, the sort of a lighter yellow curve is chemotherapy. So that subgroup, we already kind of knew about it. Well, if you look at directly under that, PD-L1 over 1%, you see that if you extend the Kaplan-Meier curve over time, pembrolizumab does seem to be at least equal, maybe a little bit better than chemotherapy. We've talked about the crossing of the lines in the beginning of this particular curve. Nonetheless, in the intent to treat patient population, the study was positive, and therefore pembrolizumab now can be used in patients with PD-L1 over 1% expression in lung cancer. Most of us in the academic circles kind of think that the majority of the benefit that we see in Keynote 042 comes from patients with higher PD-L1 level. Nonetheless, the approval is there. What about Keynote 189? Well, this is one of those rare clinical trials that actually changed our clinical practice almost overnight. The concept was rather simple. Pembrolizumab by itself can be effective. Chemotherapy is effective. Is it possible to combine the two and see what happens? Well, following some phase 1 and 2, establishing safety of the combination, a randomized clinical trial was conducted in patients with non-squamous non-small cell lung cancer, where, again, patients were randomized to standard platinum doublet chemotherapy versus the same chemo backbone with pembrolizumab grafted on top of it. And quite simply, every single clinical efficacy parameter that we follow, PFS, OS, response rate, was in favor of adding pembrolizumab to chemotherapy. Now, on the right-hand side of the curve, you see that no matter what the PD-L1 cutoff is, patients still seem to benefit from the combination of pembro with chemo. Again, the dark color curve is the combination with pembro. The lighter color is chemotherapy alone. And it is interesting to note that even in PD-L1 negative tumors, shown on the far right-hand side, which is less than 1%, basically negative, the chemo combination did seem to have clinical efficacy over chemo alone. So that was in non-squamous. Keynote 407 was conducted in patients with squamous histology. And again, the same principle exists, that chemotherapy added to pembrolizumab can have clinical efficacy. What about IMpower 110? IMpower usually refers to studies done with atezolizumab, a PD-L1 inhibitor. And again, a nicely conducted phase 3 randomized clinical trial, patients with high PD-L1 expression, which in this case, if you notice, is defined as either tumor cell or immune cell positivity, much like we just saw from Sanjay's presentation, were randomly assigned to atezolizumab versus chemotherapy. And in the PD-L1 high group, again, the dark color curve on top is atezolizumab. The lighter color on the bottom is chemotherapy, quite clearly indicating that in this particular patient population, atezolizumab as a single agent is a very good option compared to chemotherapy. What about a combination of two different checkpoint inhibitors? Well, Checkmate 227 is another one of the studies that actually evaluated the combination of ipilimumab plus nivolumab. Now, we know from the world of melanoma that this combination has been used there quite frequently with some success. In the world of lung cancer, we had to define the dosing and schedule of delivery of ipilimumab that was tolerable and manageable, so it's a slightly different schedule. But nonetheless, in patients with any PD-L1 expression, as shown on this particular graph, combination of ipi-nivo is better than chemotherapy. And for this particular regimen, we have 3-year survival data, as you see on this particular graph. Now, The interesting thing here is that the FDA approval for this combination is in patients with PD-L1 over 1%, as shown on the left-hand side, and that's sort of a little bit busy slide comparing ipi-nivo to nivo alone to chemotherapy. But interestingly, on the right-hand side, PD-L1 negative tumors also seem to benefit from this combination, but because they were not part of the primary analysis of this particular trial, the current regulatory approval is in PD-L1 over 1%. So if we come back to our case, how do we use PD-L1 expression to decide how to treat patients? I would say in my practice, someone who comes in with a PD-L1 expression over 50%, the higher the better, I think one of the first things that I think about is the use of single-agent pembrolizumab. Why? It's simpler. I don't have to use a chemotherapy backbone. Clinical efficacy is clearly established. And if certain other clinical criteria are met, then I think the use of a single-agent checkpoint inhibitor can be very, very appropriate. On the other hand, from the way I look at the data with PD-L1 lower expressions, less than 50%, I think the clinical efficacy for either a combination of ipi-nivo or chemo plus a checkpoint inhibitor is clearly the right way to go for our patients. The bottom line is that using a biomarker like PD-L1, we can to some extent personalize the delivery of care. Instead of having to say everybody who walks in can get chemo plus a checkpoint inhibitor, or everybody can get a dual checkpoint inhibitor, we can sort of fine-tune what a particular patient might need and therefore simplify the treatment approach for these patients.
Thank you, Has. That was, I'll always learn something extra on top of what I already knew from every time you give a talk. So thank you so much for addressing those questions. We're now going to take a look at some of the questions that were submitted to us by the audience. So one of the questions we got was regarding the different PD-L1 assays, what is the best way to put PD-L1 testing in practice? This is a great question. Should we use 4 different assays with different scoring systems based on indications, or are the comparable ones interchangeable? And how many clones of PD-L1 should academic or smaller labs have in-house? So these are really great questions, really get to the core of how you make this thing work in practice. So I'm going to have both of you chime in and give your impressions if there's anything you'd like to say about this, but I'll just give you my take on this. First of all, there is a demand, there's a demand from every subspecialty to have specific antibodies for their indication. So definitely the demand exists. And certainly there is some data to suggest that most of the antibodies are interchangeable except for SP142, which tends to be an outlier in some of the studies, in Blueprint, for example, and in others. But the other ones are mostly interchangeable with each other. Having said this, big labs, the core difference I think is between big labs and small labs. So big labs that can afford to have multiple antibodies in-house, large reference labs, can afford to have multiple antibodies in-house, do different scoring systems. So for example, at our institution, I do the 22C3, somebody else does the SP142 for breast, somebody else does one for urology, one does one for GE. So in a huge, group like ours, it's possible to have 4 different clones in-house and do this. But for a small lab, this is absolutely impossible to do. So for a small lab, I think the only options are either have one antibody and ask your oncologist if those are interchangeable, or send out to some lab that does all 4. But I'm really curious to see what you have to think. Jonathan, what are your thoughts on this issue?
Yeah, thanks, Sanjay. So the Brigham is obviously a fairly large academic practice. We have a lot of immunohistochemistry set up here. But even for us, we found it was really sort of infeasible to set up multiple different staining platforms to sort of support, antibodies that were specific for each individual tumor type that was being tested. So we actually use one antibody across almost all of our different tumor types, and that's run on a single platform. And I think, we've investigated fairly extensively and shown sort of what's also been reported in the literature, which is that outside of SP142, you can generate fairly equivalent performance using a single antibody. And so I think that is really an option to consider. You have to be thoughtful about the implementation, but I think that makes things sort of increasingly straightforward as more and more tumor types get added to indications for PD-L1 testing, and can make that much more straightforward, especially from the actual IHC lab perspective.
Thank you, Jonathan. I think it really helps. It really helps to know what each institution is doing, because then the person who's listening to this would say, well, I'm not an outlier in having difficulties with this issue. Everybody's facing difficulties with this issue. Haas, would you like to jump in and say, from your perspective, does it matter to you if a lab has a particular antibody, or do you agree with this interchangeability thing? How do you see it from your perspective?
So, as you pointed out, at least in the lung-centric world that I live in, the Blueprint project clearly established that there really aren't major differences between these antibodies, with the exception of SP142 that you mentioned. And therefore, from my point of view, these are all interchangeable. Now, if you ask me as an academic clinician, what do I do if I'm designing a clinical trial just because, comparison and all that, I think that's a separate question. But in everyday clinical practice, I don't see any difference in terms of which antibody you use to select patients for the various treatments that we have talked about. I think it is really unreasonable to expect all the labs across the country to have access to all 19 platforms and antibodies. It's just not a feasible thing.
I'm so glad to hear that, Haas. I mean, I'm sure there'll be a million pathologists in the audience cheering you on as you say that, because it really is a problem for us. Can I ask you for your thoughts on this we have another question on what are the recommendations for repeat PD-L1 testing in recurrent or relapsed carcinoma cases when initial biomarker testing has been negative? This is a practical problem because sometimes, you'll get one biopsy and then 6 months later or 2 years later, you'll get another biopsy. And my general principle has always been the further out the interval, the more likely I am to consider retesting. But I would like to ask Haas, from the oncologist perspective, how do you approach that? When do you retest for PD-L1?
That's a good question. We do a lot of rebiopsies now in the world of lung cancer because we have different biomarkers that we have to choose. And, in some cases, for instance, in the case of patients with molecularly driven tumors, we clearly know that different clones and mutations arise, leading to a retest or requirement for retesting. In the world of immunotherapy, I agree with you that if the interval between initial presentation and testing and recurrence is long, for instance, somebody who had a surgical operation and now 3 years later they have a recurrence, I would definitely ask for a retest of that particular tumor at the time of progression. However, if somebody is on, let's say, a single agent checkpoint inhibitor and within 6 months are progressing, I don't have any clinical data to say that retesting at that point is going to change anything. The caveat here is that, again, as you've shown very nicely in one of your slides, this is a heterogeneous staining and biomarker, such that one end of the tumor can be very highly positive and the other end could be basically negative. And we've seen plenty examples like that. So the question really is that can you get lucky enough to have the biopsy needle go exactly where the tumor is positive and therefore change the treatment landscape? So at the current clinical practice, at least in the world of lung cancer, I don't ask for repeat PD-L1 testing at every progression, but again, long intervals, a couple of years, then I do retest.
Thank you, Haas. That makes a lot of sense. There's a lot of very, very good questions, but I'm going to, in the interest of time, and because we have such a great talk coming up from Dr. Novak, I'm going to move on to Dr. Novak's section. So Jonathan, welcome and please take it away.
Thanks, Sanjay. For the second part of our talk, we're going to turn to molecular markers that can inform immunotherapy decisions. So to frame our discussion, here's a diagram that depicts the overall landscape for immunotherapy biomarker testing, which we can broadly break down by how individual markers are regulated. Although this distinction is a little bit artificial, genomic markers are determined at the level of DNA changes, while phenotypic markers are protein-based or relate to cell function or presence. As you can see, many markers and alteration classes have been proposed in a flood of literature over the past 6 to 7 years. However, as we touched upon at the beginning of the talk, only 3 markers have received approval from the FDA, including PD-L1 IHC, microsatellite instability status, and tumor mutational burden. Since we've already discussed PD-L1 IHC, let's turn to MSI and mismatch repair status testing. So we'll start with the case of a 38-year-old man who presented with a change in bowel habits and 20-pound weight loss. He was found to have a nearly circumferential mass in the sigmoid colon that was unfortunately unresectable. A biopsy of the mass, which is positive for adenocarcinoma, is shown on the right. Like many institutions, we perform universal MMR-IHC testing on all newly diagnosed colon cancers at the Brigham and Women's Hospital. This revealed intact expression of all 4 MMR proteins. When this happens in patients under 50, we reflex to microsatellite instability testing by PCR. Interestingly, this showed an MSI-high phenotype in all 5 markers that we tested. Subsequent germline testing for the patient revealed that they carried a pathogenic missense mutation in MLH1, which is one of the core MMR genes, and this substituted arginine for glycine at position 98. This alteration appears to block normal MLH1 function without impacting protein stability, leading to an apparent discordance in MMR, IHC, and MSI testing results. We also tested this patient's tumor using OncoPanel, which is a somatic-only targeted NGS panel that covers about 450 genes that was developed here at the Brigham and Dana-Farber. This showed that the tumor had a very elevated mutational burden of almost 40, and this was higher than about 93% of all prior colon cancers that we have sequenced using our panel. And when we looked also in comparison to all tumors that we had sequenced in the past, this was higher than about 98% of those tumors. Additionally, signature analysis indicated that the tumor was indeed MMR deficient or MSI high, which was consistent with the PCR testing. You can see the genomic profile of the tumor at the bottom in the plot with the different colored chromosomes, and this has a very low degree of aneuploidy and is very flat, consistent with most MMR deficient colon cancers. So identification of MMR deficiency in this colon cancer from this young Lynch syndrome patient provides eligibility for several immunotherapy options. And these include pembrolizumab, which could be used following progression on FOLFIRINOX, or now as a first-line treatment for unresectable or metastatic colorectal cancer. And as you can see at the bottom, either nivolumab or combination nivolumab and ipilimumab for metastatic colon cancer that has also progressed following FOLFIRINOX. As many of you know, the initial approval of pembrolizumab for MMR-deficient colon cancer in 2017 was also accompanied by a much broader approval for use in unresectable MMR-deficient solid tumors of any type that had progressed following prior treatment. So this is data from the 2015 paper, which is really one of the seminal papers which demonstrated that patients with MMR-deficient colon cancer had significantly longer overall survival when treated with pembrolizumab as compared to MMR-proficient patients. And while nearly half of the patients enrolled in the study had colon cancer, a variety of other MMR-deficient tumor types were also included, and you can see those in the pie chart in the upper right. As the waterfall plot shows, significant responses were seen in both colon cancer and in many other tumor types. And a subsequent study that focused on immunotherapy for non-colorectal cancer MMR-deficient tumors formed the basis for the pembrolizumab approval. So as pathologists, we're called upon more and more often to assess mismatch repair status for tumors, and we have several assays at our disposal. PCR testing for instability at a small number of selected microsatellite loci has traditionally been considered the gold standard for MMR testing. Comparing microsatellite length between tumor and normal DNA is a direct readout of MMR pathway function. However, this testing requires both tumor and normal DNA for optimal interpretation. It has limited sensitivity in low tumor content specimens and is not always widely available. In contrast, immunohistochemistry for MMR protein expression is widely available and imposes no specific DNA requirements. Although assessing MMR protein expression is a proxy for the true status of MMR pathway function, it turns out that protein status is very well correlated with the overall MMR pathway status, and this makes IHC a very good screening tool for MMR deficiency and one that most pathologists are comfortable interpreting. More recently, a variety of approaches have been developed to use NGS data to identify MMR deficiency. And these methods are often akin to traditional microsatellite instability testing by PCR, except that they can look at dozens or hundreds of microsatellites in a tumor instead of the 5 to 10 that are typically assessed using PCR. While NGS has similar data quantity requirements as MSI testing, it can be performed using tumor DNA only and can also provide lots of important information beyond MMR status. I think it's important to note that none of these methods are individually perfect, and as our case illustrates, an MMR deficient tumor from a Lynch syndrome patient, which you think would be a slam dunk for getting everything right, can still actually show intact MMR IHC. And I think it's clear that reflex testing is certainly needed in a subset of tumors. So let's move on to our second case. And this is a 57-year-old man who presented with dysphagia and was found to have a distal esophageal mass. Biopsy revealed poorly differentiated adenocarcinoma that was HER2 negative. He was started on epirubicin fluorouracil oxaliplatin, but eventually progressed. On the basis of PD-L1 positivity by IHC, he then underwent treatment with pembrolizumab, initially achieving a partial response before subsequent progression. Sequencing of his tumor revealed an elevated mutational burden of 51 mutations per megabase, and we can also compare this to the prior esophageal and gastric cancers that we've sequenced, and it was higher than about 98% of the 1,000 or so esophagogastrics that we had sequenced in the past. Interestingly, NGS analysis also showed that this tumor was MMR deficient, which would be very consistent with its elevated TMB. And the copy number profile that we see here is also very, very flat, especially for a gastroesophageal adenocarcinoma. And this is again consistent with the mismatch repair deficiency as the general mechanism of genomic instability for this tumor. So, unlike colon and endometrial cancer, we do not perform universal MMR testing for upper GI cancers, nor do I think most other institutions. However, identifying MMR deficiency in all advanced solid tumors is now, of course, therapeutically relevant. And this plot is from an NGS analysis of 18 different tumor types and illustrates the challenge of implementing universal MMR testing. While endometrial, colon, and gastric cancer is shown on the left, all have rates of MMR deficiency between 20 to 30%. Rates very quickly fall off for other tumor types, although they're not zero. And very many solid tumor types are known to develop MMR deficiency, albeit at low overall rates. And so our institution and others often rely upon NGS for MMR screening in these tumor types with low rates of overall MMR deficiency, because the NGS will also help you inform you about other potentially targetable driver alterations. However, even doing this can sometimes be challenging because the signature of MMR deficiency can actually look a bit different across tumor types. And this point is made by the bottom figure panel, where the percent of unstable microsatellite loci varies significantly even between tumor types, which you can see as you compare across the different box plots. And this is even true for the tumors with high rates of MMR deficiency. And I think this illustrates that an optimal cut point for one tumor type may not actually be optimal for another. Additionally, you can also see that there's really a continuous spectrum of loci instability, and there's not really an obvious bimodal distribution in any particular tumor type that would suggest a natural cut point. So finally, let's turn to the related topic of tumor mutational burden. So this case is a 72-year-old who developed pancreatic acinar cell carcinoma that was metastatic to the liver. The biopsy is shown on the right, and surgical pathology workup supported the diagnosis of acinar cell carcinoma. Relatively few treatment options are available for acinar cell carcinoma. This patient was initially treated with FOLFIRINOX and then with niraparib, which, as many of you know, is a PARP inhibitor, on a clinical trial basis because sequencing had showed that there was a loss of function mutation in BRCA2 in this tumor. However, that ultimately didn't produce a great response for the patient, and they resumed treatment with FOLFIRI, after which they unfortunately continued to progress. And so, similar to our previous cases, sequencing was performed on this tumor and revealed a tumor mutational burden of 11, which is much less than the other two cases that we looked at. However, if we compare this across all of pancreatic cancer that's been sequenced by our panel, this is still very high for pancreatic cancer, higher than about 90% of all of our other cases, which it should be fairly noted are more pancreatic adenocarcinomas than acinar cell carcinomas. You can also compare this to everything we've sequenced in the past, and it comes up at about the 86th percentile. And this tumor was actually found to be MMR proficient, not deficient, even though it had a slightly elevated tumor mutational burden. You can see up in the upper right, the red arrow indicates where this tumor lies in comparison to the TMB of all other pancreatic cancer. And here's the copy number plot at the bottom, which shows a very high degree of chromosomal instability or aneuploidy, which again is something that we generally don't see in MMR deficient tumors. And so for this patient with not many other treatment options available, a question which came up in our tumor board was, would this slightly elevated mutational burden be strong enough evidence to use to consider using an immunotherapy option for this patient? And would that actually make us think that this patient is more likely to respond? And so maybe I'll invite some input from Haas at this point, recognizing that you are by no means a gastrointestinal oncologist, but you've probably encountered this sort of situation in lung cancer. And have at least thought about what you might do with a borderline or just kind of marginally elevated mutational burden.
So thanks, Jonathan. I think that's a really great question. I'd like to divide this into two separate categories. There's a practical aspect. What do I do with a patient who's sitting in front of me? And then there's the clinical science aspect of it. The practical aspect tells me there is an approval for TMB over 10. However that's decided, it's a separate discussion. And I'm faced with a patient who does not have a lot of good options. The checkpoint inhibitors have shown some clinical efficacy in high TMB. And therefore, if I am faced with a patient who's had standard chemotherapy, has been through a clinical trial, and unfortunately there still is evidence of tumor progression, then I think it's very reasonable from a practical point of view to use the approval, to use the drug with the hope that we can have an impact on the tumor. From a scientific clinical aspect, at least in the world of lung cancer, I have to question what is the utility of high TMB, because yes, I'm aware of the study showing that high TMB defined as 10 mutations per megabase and higher can benefit from a single agent checkpoint inhibitors. However, in my world, I have plenty of data to suggest that TMB cutoff is really not a clinical predictor. And therefore, I might have less inclination to use TMB at this point as as part of my clinical decision making. So the practical aspect of this case says it's a very reasonable option. I mean, you're showing us data that this particular tumor has a very high TMB, and that might be an intrinsic characteristic of this tumor. Therefore, there is a good rationale for using a checkpoint inhibitor in this case, whereas in a case of lung cancer, that practicality might not be applicable because we use IO a lot. And also, how do I reconcile lung-specific data telling me that TMB is not as good of a biomarker right now? I don't know if that answers your questions or makes sense or not, but I'm happy to expand on it if needed.
Oh, thank you, Haas. I think that those are all extremely relevant points, and I feel like at our various molecular tumor boards over the past sort of 8 months or so since the pembrolizumab approval, we have the same discussion kind of again and again, and it's just very hard to sort of understand the optimal way of using TMB, which is useful but perhaps imperfect in sort of a lot of different scenarios. So just to be clear, since we've already kind of touched upon it, in June of last year, pembrolizumab was approved for the treatment of tumors with an elevated TMB that was measured using the Foundation 1 assay, which is a targeted sequencing assay that is somatic only and was used to analyze these tumors. And so that's kind of what has been considered the true sort of measure of TMB for these cases. And the data supporting that came from multiple cohorts that were part of the Keynote 158 study, which we'll review in just a moment. But before we do that, I just wanted to highlight a little bit of the development of TMB as an immunotherapy biomarker. And this began really with observations in melanoma and non-small cell lung cancer that linked elevated TMB, albeit imperfectly, to a better response to PD-1, PD-L1 axis inhibition. And over the next several years, trials expanded into additional tumor types, though with a continued focus on lung cancer, melanoma, and then also bladder cancer. Interpretation and comparison between many of these studies was challenging, however, because of significant variability in technical considerations for TMB calculation. And there were a number of harmonization efforts, some of which are depicted here under 2018-2019, that were started to begin to address this problem. Before we move to those, though, let's just take a quick look at the data from the trials that were included in Keynote 158 and that led to the pembrolizumab approval last year. So as the waterfall plots on the left show, there were significantly more partial or complete responses amongst TMB high tumors, which are on the left, as compared to non-TMB high tumors as shown in orange. And even amongst the TMB high tumors, which are in blue, responses were seen in both the MSI high and the non-MSI high tumors. And the Kaplan-Meier plot on the right depicts the improvement in progression-free survival for TMB high patients, which is about 22% at year 2 compared to 7% for TMB low tumors. While these data were very exciting and were accepted by the FDA for a pan-cancer TMB approval, it's important to know that they came from a relatively modest and honestly somewhat unbalanced survey of tumors as shown here. So across GI tumors, for example, only anal squamous cell carcinoma, biliary tract cancers, and some neuroendocrine tumors are represented in these studies. And many of the major GI tumors are actually not here. And it can therefore be somewhat challenging to extrapolate from these data to guide a particular patient's decision. So one of the biggest challenges for TMB calculation and reporting are the many factors that can influence our TMB result. At the level of sample collection, should a primary tumor or a metastasis be analyzed? Is a biopsy as good as a resection? For DNA processing, tumor content can influence variant detection rates. Sequencing can be performed on panels of various sizes or could be whole exome sequencing. Sequencing can also be tumor-only or paired tumor-normal. For bioinformatic processing, what types of variants should actually count for mutational burden? Does subclonal variants count as much as clonal variants? And finally, for reporting, should TMB be reported as a continuous variable or should it be quantized? And if it's going to be quantized, what cut points might define high and low? And this information is really crucial for determining clinical actionability. So while these considerations may kind of seem dry and technical, they do impose real-world challenges for comparing TMB across assays. And this slide depicts key features of the Foundation NGS assay, which is the official companion diagnostic, and it's being compared to a typical whole exome sequencing assay, as well as the Memorial Sloan Kettering Impact assay. Each of these, of course, covers a different number of genes and a different amount of genomic real estate, if you will. Whole exome sequencing and the Impact assay are paired analyses, while Foundation is tumor-only and uses bioinformatic approaches to remove germline mutations. And each assay, therefore, really has differing sensitivity for detection of true somatic mutations. And as these two problems were first being recognized a number of years ago, two of the major TMB harmonization efforts started. And one of those was through the Friends of Cancer Research effort, largely based out of the US, and the parallel QUIP effort that was largely based in Europe. So the Friends of Cancer Research Group is comprised of many academic and commercial labs, along with the NCI, the FDA, and pharmaceutical partners from industry. And this work has proceeded in a couple different phases, which were designed to initially identify sources of TMB variability across assays, to define a set of universal reference standards for TMB alignment, and finally to propose standards for defining TMB for use in clinical applications. And these data from the project on this slide were presented at the 2020 AACR meeting and depict the degree of variability between labs when using panel-based TMB measurements to estimate whole exome sequencing-based TMB, either as a bioinformatic exercise using TCGA datasets or via direct sequencing of cell line samples or tumor-normal FFPE clinical samples, as shown on the far right in the box. So the TCGA and cell line data, it's thought, can be used in this context as reference calibrators to help improve the concordance between labs for clinical specimens. This work is ongoing, but will hopefully provide a much better and hopefully more standardized way for labs to measure and report TMB in the future. So one particularly challenging issue for interpreting TMB, once it's been calculated, is the cutoff or cutoffs that are needed to define high and low. And the current cutoff, as you remember, is a 10 mutations per megabase cutoff across tumors. So this recent study utilized immunotherapy response rates in TMB data from patients with different tumor types, all of which were microsatellite stable. And it found that there was no clear single cut point that optimally distinguished between responders and non-responders, as you can see from the near linear relationship in the plot on the left. When the authors then looked at TMB as a percentile scored within each tumor type, the shape of the curve shifted, with a flatter portion at TMB percentiles less than 80% and a more steeply increasing response above 80%. So these data suggest that a TMB of 12, for example, in one tumor type is really not equivalent to a TMB of 12 in another tumor type from the immunobiology perspective. And I think this suggests that there's likely room to improve the predictive power of TMB for immunotherapy response. So in our final few slides, I think it's fair to point out that the immuno-oncology biomarker field is changing very rapidly. Some of the major axes of ongoing investigation are shown in the diagram on the right. And in addition to refinement of available markers, it's likely that we'll see significant efforts to integrate interpretation across existing biomarkers. Finally, I think it's very possible that additional markers, perhaps most likely immune cell measurements, will cross over from investigative or research use into approved diagnostic usage. So as a continuation for our final case, which is this metastatic acinar cell carcinoma with a slightly elevated TMB, we decided to perform multiplexed immune profiling using the Immunoprofile assay that was recently developed at our institution. So this assay allows us to use a computer to quantify PD-1 and PD-L1 expression along with CD8 cytotoxic T cell density and FOXP3 regulatory T cell density using standard FFPE material. And the fluorescent images of the case pre and post digital image analysis are shown on the right. And this study revealed that the tumor had essentially no PD-L1 expression, whether measured by TPS or CPS. We don't know which one to use because none is validated for acinar cell carcinoma. And also, this showed that T cell densities were very low. We can take a page from TMB analysis and compare these measures to previously profiled pancreatic cancers and other tumor types that were studied using Immunoprofile. And when we do this, overall, this tumor ranks mostly in the single-digit percentiles, indicating very low PD-L1 and immune cell densities compared to other tumors. Thus, despite a TMB that would theoretically qualify the patient for pembrolizumab, I think the immune microenvironment profile of this tumor would really dampen your enthusiasm for such an approach. So this meta-analysis from 2019 explored the relative utility of different biomarkers, different classes of biomarkers for predicting immunotherapy response, either alone or in combination. And overall, these results suggest that integrating multiplexed analysis of the tumor immune microenvironment can add additional power to what you can learn from TMB and from looking at just PD-L1 expression on its own. And while this is by no means standard practice yet, I think it's important to become aware of because it might start to be how we integrate some of these biomarkers in the future. So with that, we have time to address quickly a few questions that have come in for the second portion of the talk. Some of these we've already touched upon in the prior slides, but a couple that stand out are one addressing whether MMR protein expression decays over time, similar to PD-L1. And I would say that although this is probably true to a certain extent, one important feature of MMR protein expression is that we're always looking for an internal positive control that's expression in the non-neoplastic cells in our tissue. And so we hopefully have that internal positive control that we can always use to ensure that antigenicity in the slides that we're staining is still intact. And then another question here that we haven't exactly hit on yet is whether the unstable loci in MSI-H tumors are the same across all tumors, and if not, what are the implications for testing by the current PCR approaches? I think that this issue wasn't really appreciated historically when most testing was focused just on colon cancer and endometrial cancer. But as we've now really expanded to all solid tumor types, it's increasingly clear that although many hotspots or particular microsatellites are recurrently affected across different tumor types, the patterns of which types of hotspots or microsatellites are altered can really vary tumor to tumor, as kind of does the overall level of microsatellite instability. I think we're sort of at the point of recognizing that, but not necessarily using that information at a tumor type specific kind of implementation yet. And then sort of the final question here that maybe we can close on as we bring in our other presenters is asking how we can implement and generalize the use of this biomarker in practice. And I think with that, we can move to sort of our final portion of the talk, which is really bringing this together. And I think that as we think about the three markers that are approved right now, Each of them really offer their own challenges, not only for the laboratory in terms of the best way to do the testing, and this is certainly true for PD-L1 IHC, which platform, which antibody, what's sort of the best practices for scoring, to MMR, where you have multiple methods for testing in the lab. None of those are perfect. Each has its own kind of advantages and disadvantages. And then most certainly for TMB, where there is still kind of significant work to be done to establish sort of best practices for TMB calculation and reporting, and where I think many of us feel like the best ways to do that may not actually quite match what the existing approval is for. So it's certainly an exciting time in this area, but there is still a lot of uncertainty evolving kind of for each of these markers and the absolute best way of testing them. So I guess I'll just ask both Sanjay and Haas, if either of you, maybe we'll start with Sanjay first, would like to offer kind of further thoughts or comments.
Yeah, thank you, Jonathan. That was really a wonderful talk. Just very, you really addressed a very complicated topic in a beautiful way. I would say, from my perspective, for this audience, our audience at USCAP, I would say the main important thing to remember in the current day is that your diagnosis doesn't just end with the diagnosis. You, at least in the lung cancer sphere, you have to think of what is going to happen next with the patient and what else needs to be done. Do you need to do molecular testing? Do you need to do PD-L1 testing? So you cannot assume that your job is over when you sign out, what kind of a tumor it is. And so you always have to be thinking of minimizing unnecessary immunostains, conserving tissue, and especially preserving tissue for molecular testing and PD-L1. With that, I'll turn it over to Haas for your final thoughts, Haas.
Look, I think if anything, this clearly indicates that we're entering into a very complicated time when it comes to the use of tumor samples, as you pointed out, Sanjay, and how best to utilize the available test in order to help patients, have the right treatment offered to them. I think a couple of things struck me as Jonathan was presenting. First of all, we tend to isolate biomarkers, and I think the point was made when I think it's a very accurate point at that last slide, that in reality, one biomarker is probably inadequate, and multiplexing of multiple biomarkers is probably needed. As beautifully that case with TMB high showed, if the tumor has no T-cell infiltration, you can throw all the checkpoint inhibitors you want at it. You're probably not going to have the clinical efficacy. So how do we change that tumor microenvironment? And how do we multiplex out of this? And how do we do it in a timely fashion so that right treatment decisions can be made? Not everybody is going to have access to a multiplex immunofluorescent antibody platform the way MGH and Dana-Farber and Brigham has. So how do we, in a way, socialize that so that everybody has access to it? And I think these are really important questions that we're going to have to collaborate with each other and find the right answers to. But we're never going to be happy with one biomarker because they all have faults, and multiplexing them is probably going to be the key to finding the right patient for the right treatment. But what those multiplexes and how to do it, I think it's a separate discussion. Like Jonathan didn't even touch upon the potential of using liquid biopsies to determine TMB, which has become a big issue now. It might be a little bit more accurate than tumor because it considers the entire tumor and not just where the biopsy was conducted. So I think there are a lot of unanswered questions, but the important thing for me is that we are on the right track. We've taken the initial difficult steps. We're defining this, and hopefully the future will help us even better define the patient populations who would or would not benefit from the treatments that we have discussed.
Thank you very much. With that, I would like to thank both Dr. Novak and Dr. Borgai for just educating us and teaching us so much about the current state of affairs in immuno-oncology. Finally, I would like to end with thanking the audience. Thank you for spending your time with us and investing in your education. Thank you so much.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.